My name's Yvonne Burks, for those of you who don't know me. I'm the Deputy Director of the School for Social Care. So a very warm welcome to this webinar, which has a focus on dementia. It's great to be here and great to be running the third one of I think it's the third one. And we've got two presenters today. So the first person that we have is Kitty. Kitty is one of our very first SSCR doctoral fellowship award holders, which is fantastic. We made an award of 5 of these, I think, and we have some other people who are doing career development awards and doing PhDs as well. But it's fantastic to be able to do that, and very brave of Kitty to be the first person to offer to share her topic with us, first of all. So what I'll do is I will hand over to you, Kitty, and you can share your slides with us and give us your presentation. Thank you very much.
All right. Okay, can you see and hear me?
We can.
Great. Okay, so this is a presentation that explores the intersection of bisexuality and dementia. My name is Kitty Clucas. I'm a PhD candidate at the University of Bristol, and this research is funded by the NIHR School for Social Care Research. So before I discuss the research, it's important to clarify some terms I'll be making reference to. So first we've got what is LGBT+. That stands for lesbian, gay, bisexual, transgender plus community. The plus symbolises people that are a part of the community, but don't explicitly use the terms lesbian, gay, bisexual, or trans. This could include queer, asexual, intersex, non-binary, pansexual, and fluid people. So I find the acronym LGBT+ is often used in 2 different ways. Often it is used in reference to community. This acknowledges that LGBT+ people have a shared history. We all have varying experiences, but we all suffer under a heteronormative patriarchal society. Heteronormative means the assumption that everyone is straight or heterosexual. We protest, party, and exist in the same spaces and we choose to advocate for one another. The other way that LGBT+ is used is in reference to being a minority. This is the way it is most commonly used in research. There's technically nothing wrong with this because LGBT+ people are a statistical minority and we experience life differently from cisgender straight people. Cisgender meaning you identify with the gender you're assigned at birth, so people who aren't transgender basically. However, LGBT+ can sometimes be used by researchers as shorthand for not straight. This can be problematic because it often ignores gender minorities, such as trans and non-binary people, but also bisexual people, because it prioritizes the voices and experiences of cisgender gay men and lesbian women who make up the whole or vast majority of research samples, despite the research being called LGBT+. Sometimes research will seek to address gender differences by researching lesbians and gay men separately, but often the only exposure bi people will get is when they group bi women in with lesbians and bi men in with gay men. Bi people have very different experiences to gay and lesbian people, which I will soon demonstrate. And such research often never includes trans people who can also identify as lesbian, gay, or bisexual. So this brings on to the next thing of what is bisexuality, which is a whole other thing. There is no unanimous definition of what bisexuality is, both within the bi community and in the academic world. This is probably one of the reasons why bi people are such an under-researched group. So I don't have time to go through all the different ways that bisexuality can be defined, so I'll just use the examples that I will be using. So Eisner in 2013 came up with the definition of community. So identify with bisexuality for political and social reasons. bi community sees bisexuality as a shared identity, political and transgressive movement that carves out a space in sexuality studies specifically for bi people and their emancipation. And also umbrella term, which covers anyone that does not identify as homosexual or heterosexual. Pansexual, queer and fluid people may not specifically identify as bisexual, but they associate themselves with the bi community because they have similar experiences. And then Savin, Williams and Cohen, I'll be using also the definition of primary. So people who identify with bisexuality as their primary sexual orientation and as one of their protected characteristics. I'll be using bi identity in reference to community, umbrella and primary, because my research is less concerned with things like sexual health and like sexual partners, but rather identity and biphobia and how bi identifying people are the most relevant to this research. So my research is exploring the intersection of bisexuality and dementia in social care. I am asking, how are bisexual people with dementia figured? What are the experiences of bisexual people with dementia who use adult social care? And what are the barriers bisexual people face when accessing dementia social care? My aims are to improve the experiences of bisexual people with dementia in social care and detail how dementia services can be more inclusive of bisexual people. I will be using a post-structural theoretical perspective that is critical of what we assume to know about sexuality, identity, and dementia. It will draw on influences from queer and crip theory, theories that disrupt truths in regard to sexuality, age, disability, and illness. My main priority is to recruit people who identify as bi and have dementia, and possibly the partners and carers of. But from some initial research, I think I'll be very lucky to manage to recruit even one person who identifies as bisexual and having dementia, because it's such a covert population, bisexual people are. So I'll be supplementing the data with interviews from bisexual people over the age of 60. So although these participants don't have a diagnosis of dementia, it's hard, like ageism and gerontology are so tightly wound with how we see dementia that I think it can be pretty relevant. Participants will mostly be accessed through LGBT+ specific dementia and older persons groups and general dementia charities. I will also approach bisexual organisations and social groups, and I will leave recruitment materials in places where older bisexual people might hang out. So that would be gay bars, community centres and HIV support groups. I refer to the Mental Capacity Act of 2005 and its section on research when it comes to getting informed consent from people who may lack mental capacity. I will conduct a thematic analysis of the transcript data, and with feedback from participants, I might possibly create a toolkit or leaflet for services and or by people seeking dementia care services, and of course my PhD write-up. So I had a meeting with some bisexual activists, and these were kind of some points of interest that they wanted to see addressed in the research. So how are bi people with dementia treated by care services, peers and loved ones? How could memory loss affect your bi identity, both in terms of how you view yourself and how others view you? Also, some research shows dementia puts LGBT+ people at risk because they are more likely to reveal their identity in an environment that they normally wouldn't. However, some have argued there is a freeing aspect to cognitive impairment where some people with dementia may feel less concerned how others view them and use it as an opportunity to explore or renegotiate their sexual orientation. Ward and Price in 2016 write an interesting paper on this, of dementia as a transgressive space. So then another question is sexual health and happiness like talked about at all in regards to bi people with dementia. How are families or partners involved in identity affirmation, and how is it for bi people who are single or estranged from families? How does polyamory, which is the practice of having multiple consenting partners, romantic partners, play a role in dementia care? This is something that is more common among bi people, and also how race and gender may diversify the experience. So quickly, now I'll talk about previous literature and theories that are useful to understanding how bi identities and dementia may intersect. Understanding modern Western history of bisexuality is an important component of how bisexuality is theorized today. So early 20th century sexologists called gay people inverts. Lesbians had male brains and were trapped in a woman's body, and gay men had women's brains in a male body. Gender and sexuality were one and the same. Bi people were called intersex, different from today's definition of intersex, which means someone born with ambiguous reproductive organs. Intersex used to mean a person with a half male and half female brain, a psychosexual hermaphrodism. Then Freud became the first person to say bisexuality, but he considered it a disorder of the Oedipal complex. The Oedipal complex being the child has an unconscious sexual desire for their opposite sex parent. Homosexual people desired the same sex parent, and whereas he thought bi people just do not progress beyond this stage, and consequently bisexuality is like an arrested development. Then in the 40s, we got the Kinsey scale by Alfred Kinsey, which is the start of a long history of trying to capture human sexuality on a numerical scale. 100% heterosexual existed on one end and 100% homosexual on the other, and bi people slid somewhere in between the two. Then in the 70s, 80s, and 90s, once lesbian and gay people gained enough ground, bi people and trans people broke away and formed their own distinct movements. This was in part triggered by extensive biphobia and transphobia perpetrated by lesbian and gay men. For bi people, they wanted to make it clear that bisexuality is its own distinct identity rather than half gay and half straight. The movement was radical and based on feminist, queer, and sex-positive politics. So these are some common myths thought about bi people: that bi people don't exist, they're confused or indecisive, slutty, promiscuous, and unfaithful, carriers of HIV and other STIs, and really just gay or straight. These are hurtful myths perpetrated about bi people, but the bi community also acknowledges that some myths are based in truth. Lots of bi people are promiscuous, HIV positive, and confused, but that's okay. There is no good or bad bisexuals. We are not a monolith. Also, often you will hear gay or lesbian people who identify as bi before finally identifying as gay or lesbian. And as Taylor notes here, people do experience a lot of confusion, but this is because we live in a monosexist either or society where bi people are made to feel unwelcome. An example being the HIV crisis back in the 80s and 90s. Many people blamed bisexuals for spreading it to straight communities, often deemed traitors by the gay community, but too unclean by the straight community. So bisexual identity is categorized by an ongoing process of uncertainty and persistent confusion. So there's been research done into bisexual health and social inequalities. For bi women, their sexuality is assumed to be a performance for straight men. Straight men and straight couples often co-opt a bi woman's sexual identity and treat her as a sex object. As a result, bi women experience much higher instances of sexual assault than lesbian or straight women. Research unanimously agrees that bi people have poorer mental health than straight or gay people. This is often due to internalized biphobia, lack of community. For example, bi men are at a higher risk of being socially isolated. Many people do not believe bi men exist. Bi men are often accused of being gay and lying about it. For example, when I worked for an LGBT plus mental health charity, I often had to console men who originally identified as gay, but realized they were bi and consequently found themselves abandoned by both straight and gay friends. Bi people are more likely to be in poverty. This is especially true for gender non-conforming people who find it hard to be given jobs. Researchers have not really been able to establish the root causes of all these inequalities. So bi researchers have recommended some things for future bi research. The bi population to be researched as a distinct population separate from LGBT+. More research on bi health and mental health and the reason for these disparities. It needs to be more diverse in terms of race and class. Studies on bisexuality tend to be overwhelmingly white and middle class. Research bi-specific minority stressors and include more bi men. Bi women tend to overpopulate bi research samples too. So then it brings me on to talking about dementia, sex and sexuality in social care. So this is more general and not specific to LGBT plus people. There is little to no conversations about sex, sexual health, sexuality, etc., even for heterosexual people with dementia. Some provisions are made by care services to help facilitate relationships between married couples, but new relationships after dementia diagnosis are discouraged due to uncertainty around capacity to consent. Lots of care providers do not have clear guidelines on this. Care services often treat men with dementia as predatory when it comes to sex and often frame women with dementia as vulnerable and prone to exploitation. While of course sexual exploitation is possible in many care environments due to varying power imbalances, this does not mean all people with dementia should be considered to have no sexual agency. People with dementia are often treated like children when it comes to sex. Not only does this undermine people with dementia's experience, but when rare instances of non-consensual sexual aggression occur against staff by a service user with dementia, it is often brushed or laughed off and not addressed properly. Also, care homes often have a clinical atmosphere. This picture kind of tries to represent that do not allow formation or continuation of romantic relationships. For example, beds are always single beds, there are no locks on the doors, and common areas are filled with single armchairs spaced at a distance. This is all conducive of the belief that not only people with dementia, but older people in general should not be having sex. This is of course even further complicated for people who are LGBT+. Although sex and sexual relationships should not be considered the be-all end-all discussion in regards to LGBT+ identity, one cannot separate it from the conversation. When in our society, sexual practice is so highly wound with identity and moral code. So heteronormativity in dementia social care. So just briefly go over some key issues for LGBT plus people with dementia. Passing, that refers to passing as a straight person or a cisgender person, and wanting to be perceived as such for safety reasons. Disclosure, when should someone disclose their sexual identity? Trauma, often LGBT older people might have gone through conversion therapy or electric shock conversion therapy, which is incredibly traumatic and can make like reminiscence therapy a bit problematic. Erasure, so for example, care staff might like force feminization on butch lesbians, and this can like erase basically LGBT plus identity. Third party disclosure, will someone else tell on their sexual identity? Peer support, LGBT plus people are much less likely to be married, have children or a supportive nuclear family. So friends and access to the LGBT plus community is key. These connections are often eroded by various practical and social reasons when an LGBT plus person gets dementia. Then there's like bullying by both care staff and service users, and refusal of services. Often you hear of LGBT plus people being refused personal care by care staff because of their sexual or gender identity. So then there has been no research on on like biphobia specifically in dementia care, or the intersection of bisexuality and dementia in adult social care. But there has been some research done on biphobia in adult social care in more general. So left over from Freud's analysis of bisexuality, bisexual people are still often treated as psychological or emotionally damaged. Mental health workers such as counsellors and therapists may force bi people to identify as gay instead of considering them as bi. They accuse them of being too scared or damaged to acknowledge their true gayness. Services have very little knowledge on bi issues, although Mind, the mental health charity, did publish guidelines for mental health services on how to work with bi people. It's called Stand By Me, if you want to Google it, bi being spelled B-I. Bi people often avoid LGBT plus services because of historic discrimination by lesbian and gay people. Jones references in their study a woman who used a lesbian and gay grief service after losing her wife. She then found herself a boyfriend and the group members cut all ties with her. In another study by Jones, a woman in an aged care home was revealed to be bisexual to a staff member, and this staff member spread gossip that the woman was promiscuous and predatory. So this is just a bit about the numbers and why it's going to be important to do research on bi people with dementia. So the number of people identifying as lesbian, gay or bisexual in the UK has increased by more than a third in 4 years. And that is only going to get more and more as people feel more comfortable to disclose their identity and feel that their identity should be acknowledged as they age. So there's 850,000 people with dementia currently. This is set to be 1.6 million in 2040. So there's likely to be at least 35,000 to 70,000 plus LGBT people with dementia by 2040. We have no idea what percentage of that is bisexual people. It's incredibly hard to establish that because, like I say, bisexual people are much less likely to be out of the closet, and there's a lot of disagreement whether there's more bisexual people than there are lesbian and gay people, or whether there's less. There just isn't a unanimous answer in research. And yeah, and that is my presentation, and these are the references. So yes, I will stop sharing.
Thank you. That was extremely comprehensive and fascinating. It's quite complex.
Yeah, there's a lot to unpack in 20 minutes.
There's a lot in there. Okay, so I've got one question at the moment, and I have a quick question. You briefly mentioned crip theory, and I wondered if you could just very briefly say a little bit about that.
Crip theory is kind of similar. So it's basically like a sort of post-structural or postmodern perspective on disability, and it kind of understands that it kind of basically how a capitalist society discriminates against disabled people, essentially. So there's kind of some interesting work on like crip time and how time as we know it is a like it's a capitalist construct, and it doesn't acknowledge that people have basically different experiences of time, which might be due to like disability. It's incredibly kind of complex. It's similar to
complicated area.
Yeah, basically, but disability perspective.
And I've got a quick question here from David Abbott. David, I'm not sure that I'm interpreting your question correctly. Would you like to ask it yourself?
Oh, thank you. I was interested in, it was a brief remark, Kitty, that you made about kind of the instances of liberation that may arise in identity for someone with dementia. You said, you know, it might provide this opportunity of liberation of identity. And I think you said that there'd been a paper about that. I just wondered if you could say something else about that.
Yeah, so it was by Ward and Price in 2016, Richard Ward and Elizabeth Price, I think, and it kind of references how, and it's called like the politics of senility, and it's about essentially how dementia shouldn't, like, we shouldn't just categorize it as a period of decline or a period of illness. It can just, like, we should see it maybe more as like a fun, like a change, and it's more just a change in perspective and a change in the way of living. And yeah, like often you, like, for example, I read some studies and there was a woman who had dementia and she had traditionally identified as a lesbian her whole life, but then since getting dementia, she had started to have romantic relationships with men. And so it can, yeah, so there's sometimes a shift and a change in how the person sees themselves, and that should be acknowledged. But yeah.
We've got time for one more very quick one. So I've got a question from Francis Dickinson on here, who's asking Kitty, has there been much research on the experiences of LGBT plus people with dementia? And if not, would it be, and if it's going to be a struggle to find people who are bi, whether it's worth broadening the topic of your PhD out a little bit?
So there's actually been a considerable amount of research done on LGBT plus people with dementia in the past couple years. For example, Alzheimer's Society they have a whole thing on like how to work with LGBT plus people. Also Age UK do as well. Some names like, for example, I know like Westwood is someone who has written extensively on the subject, and Price and Ward. But yeah, I think my focus would be specifically on bisexuality, because it is so under researched, and I don't want to fall in the same trap of just recruiting lesbian and gay people. Yeah.
Okay, that's great, thank you. Kitty, thank you very, very much for that. You've set a very high bar for all the other PhD students who are probably all on here and very afraid. But that was an incredibly complex area. You did a fantastic job of summarising that for us. So if anyone has any further questions for Kitty, I'm sure she'd be happy to hear from you on the email.
Yeah, I'll leave my email in the chat.
That would be fantastic, Kitty, thank you. So we'll move on now to Paul Clarkson from the University of Manchester. And Paul is a senior fellow of the School for Social Care Research. He's worked in the area of dementia for some time. He's going to present to us today about home care and dementia. So thank you very much, Paul.
Thank you, Yvonne. Just hold on while I start. Can everybody hear me okay? Yeah, good. You can see me okay. Welcome everybody, especially in these strange times. It's a very strange phase we're going through at the moment, isn't it, with everything. I'm going to, and thanks for Kitty for kicking us off so eloquently. She set the bar quite high there, as Yvonne said. I'm going to talk to you about a project from our previous phase of SSCR, which finished last March 2019. And I'm going to focus more on leading you through as quickly as I can, because there's a lot of information, some findings from a previous study looking into home care in dementia, and particularly service delivery issues, and really the question of what components of home care, domiciliary care for people with dementia, could be considered more effective. Now, for those of us that have worked in social care or are working in social care and for people, including myself, who have struggled to care for somebody, a relative with dementia, and have gone through the labyrinth of assessments and care and domiciliary care, etc. I think everybody would agree that home care has been a challenge, particularly for dementia. There's been a lot of workforce issues, knowledge and training issues, contract issues with providers, meaning that the person with dementia often doesn't get the service that they might need and benefit from. A lot of these issues have been echoed in national reports from NICE, ADAS, Alzheimer's Society, people like that. Home care is a mainstream service in social care. It's been with us quite a while, but there's not been a lot of systematic inquiry into what works for the person with dementia and their carers. But there are indications, some from newspaper reports and national reports, etc., that home care providers that provide something additional to merely personal care in the home may do better. So things like additional things like social engagement, befriending, sitting service, etc., and really get alongside the person with dementia and help them in more than their sort of functional capacity, seem to do better. There's a suggestion of that. So this study was trying to pick up on those issues. It had 4 research questions and a mix of different ways of exploring these questions, both qualitative and using quantitative data. So the questions were, what are the key components of effective home care for people with dementia? What do informal carers think? That's family carers, informal carers. And then what are the perceptions of formal carers and formal home care providers about the issues? And then lastly, what is the relative effectiveness of different approaches that may use different components over and above personal care? So the elements of this study mirrored those research questions in terms of, first of all, a systematic literature review to work out what components of home care may be more effective. And then a survey of informal carers, and that was a co-produced survey with informal carers themselves. I'll go on to that in a second. And then a survey of providers of home care. And then lastly, a naturalistic study which used primary data from users and carers from research interviews. So a quantitative study. So firstly, the systematic literature review. This literature review was an update of a previous systematic review on dementia home support in general, and then focused down on particularly home care, domiciliary care. So the previous review was on dementia home support in general from agencies and NHS, as well as social care support, for example, community support workers, psychological support, etc., that looked at a range of components of care that were being delivered. And we tried to hone that down into whether these components of care were offered by home care or domiciliary care studies in the literature. So the previous literature review on home support in general in dementia highlighted, amongst others, these components of care, which broadly can be articulated as personal care in the home, and then additional components that may or may not be present in home care, such as sensory enhancement for the person with dementia, supporting their cognition, emotional support, physical activity, some type of physical activity involvement, modifying the environment around the person with dementia and the carer, managing the behaviour of both the person with dementia, if possible, and what the behaviour means to the carer, of the person with dementia. Coordinating the care around the person to bring it together. Social support to the carer, and lastly respite, which for home care really focused on in-home respite. So if a home carer would come and sit with the person with dementia to give the family carer a break. So the systematic literature review, here are a few findings. There were 14 international studies, 5 in the UK with some evidence of effectiveness. And there were positive impacts for the person with dementia or carer. I'll just move my picture so I can see that. With various mixes of components, which I've termed personal care plus. So personal care, but plus some other things as well. Most of the studies contained respite care, in-home respite care, and this showed positive effects on the person with dementia in terms of their health, burden on the carer, preventing nursing home admissions, and mortality survival. There was evidence for effects of social engagement, such as befriending, but this was more limited in the literature. And dementia care, lastly, as a whole, there's no magic bullet for dementia care. More components of care doesn't necessarily mean better outcomes. It's not a cumulative thing, and that was shown by the studies. Secondly, our survey of informal carers was quite a distinct and exciting survey. It was co-produced. It was an online survey co-produced with carers of people with dementia, co-designed by them with the research team, and hosted on a carers charity website for completion by carers. And the charity is Tide, which is Together in Dementia Every Day, who I've worked with previously and continue to work with. They're a national carers charity, and they're really engaged in dementia inquiry and dementia research as well as supporting carers nationally. The findings from the survey focused on the quite negative points, actually, that currently home care isn't tailored sufficiently towards the needs of people with dementia. It's a very broad service. Functional care is important, but these other components I mentioned earlier from the literature review are not really included in current contracts for domiciliary care, particularly with local authorities. There's a traditional time and task delivery philosophy in the contracts, which I think most people might be aware of, and that really doesn't provide enough sort of tailoring of care towards the person and making care person-centred. And particularly care agencies, home care agencies, tend not to work alongside family carers. They treat the person with dementia as the unit, if you will, and don't include family carers. So often family carers have to either undo or supplement care that's already been provided when the home care worker leaves. And often these are short 15-minute visits according to a set task in the contract. And carers didn't really think that was beneficial to people with dementia. So the carer survey really concluded that better training and different contractual arrangements with local authorities, if possible, might be a way forward to improve home care for people with dementia. These quotes are from the carers survey. The survey was predominantly qualitative, so it was open-ended. It was an open-ended questionnaire online. And these are kind of show both sides of the coin, both negative and positive. So firstly, positive. There were positives when the home carer could get on the wavelength of the person with dementia, become person-centred and do more than just providing personal care, which is important. Carers found that very valuable. The second quote really epitomises the time and task and contractual issues around home care at the moment, not just for people with dementia, but in all older people in general. Home carers are poorly paid, there's poor working conditions, there's a lack of continuity. You often don't see the same home carer at each visit, which for somebody with dementia can be quite confusing. And the funding in the community overall for home care agencies, there are big problems, I think, and even more so quite recently with the contracts and the businesses that are operating for home care. Next, the survey of providers. These were a telephone survey with home care providers across 5 geographical areas. These providers were chosen by from a sampling frame from a national survey where different possible mixes of services were apparent. So we approached providers with perhaps who could provide different who had different capacities to provide care. The interviews addressed capacity issues, specialisation, particularly for people with dementia, whether home care agencies had the required training, etc., and workforce issues, particularly supply issues. So the findings from the survey of providers, this is a brief run through of some of them. There's a big issue from the point of view of providers in developing a workforce that's sustainable for supporting people with dementia at home. There are many challenges. Providers, one way forward to improve care, which was a major finding from the survey, was that providers could take greater responsibility for the assessments and care planning over and above the assessments that local authority social workers do, for example, before they give the contract to a home care provider. And this is a way forward that is mentioned in the Care Act, and providers felt that if more could be done in terms of contracts, so they could actually take more responsibility for assessing themselves, the providers, they could perhaps provide more tailored person-centred care than they are doing at the moment. But overall, providers felt that they were under severe pressure at the moment in the marketplace for home care, and they found it difficult to create a respected and skillful workforce, particularly in the context of financial austerity, which, as we go into the present period, is even more of an issue, I think. Lastly, we conducted a quantitative study, which is called a naturalistic study, which really means a non-trial. We just observed home care as it's operating in a large sample of people with dementia and their carers living at home. This is a unique data set. It's very difficult, as a lot of people will be aware, to recruit people with dementia and their carers to research studies, and it's very difficult to keep hold of them and collect numbered quantitative data with them in research interviews, all sorts of capacity issues in terms of research and recruitment. But we achieved a unique data set from an already existing ongoing study, which was to look at the home support in general of people with dementia and their carers, funded through another NIHR study, a programme study. So in that study, there were 518 people living at home in later stage, more advanced dementia with their carers, who were followed up at 6 months across 13 local authority areas in England. And And these people in the sample were receiving a mix of services from the NHS, social care and support services, for example, community support workers. And we really analysed a subset of that data. And that was on 247 people who were receiving home care, domiciliary care as part of their support package, because not everybody was. We measured outcomes with standardised questionnaires, looking at people with dementia's quality of life, their activities of daily living, the competence of the carer in coping with caring demands, and whether the person with dementia remained at home at 12 months after the first baseline research interview. So a broad range of outcomes and a very unique data set and large sample. This is just one of the main findings, really, to provide a little picture of that study, quite a complex study. In terms of the objective of maintaining people with dementia at home, which is quite a simple objective, but that is the main objective of home care, not really to fulfill other outcomes of value, not explicitly, so quality of life, etc., the competence of the carer, they're all important, but the main operational objective of home care is to keep people at home for longer. So with that simple objective, we looked at the data on whether people with dementia remained at home at 12 months from the initial interview or not. And these are quite interesting findings because it shows an increase in the percentage of the sample. That's what the figures are. The percentage of people with dementia who remained at home at 12 months was 56% in a group that received only personal care as part of their home care package. And a greater percentage of people remained at home who received personal care plus some befriending element, social engagement and befriending element from the home care worker, and enhanced home care, which includes not just personal care, but things like nutritional help, medication help and compliance, etc. 89% of that group remained at home. So there's a sort of linear increasing in the proportion of people that stayed at home with successive additions to the home care package, if you will. These simple findings were backed up by multivariate findings where we controlled for various things, particularly people's chances of receiving a certain home care package, which is obviously important to control for. So in conclusion, just some main bullet point conclusions from the whole study, from the different elements of it. Home care is a mainstream service as part of social care, a crucial part of social care, the system as it stands at the moment, but systematically studying it for people with dementia is lacking. There haven't been a lot of studies that have systematically studied home care delivery itself. Evidence from the literature on benefits of certain components. There is evidence particularly for respite care, which seems to be considered particularly effective in the literature. Our survey of informal carers, there were a lot of negative aspects to that in terms of carers' opinions. They were quite dissatisfied with the home care system as it operates at the moment, but there were some positive aspects. So when done properly from their point of view, if other components were included, not just help with functional care, carers on the whole were very, very satisfied with their home care worker. But there were a lot of contractual and delivery issues, I think, highlighted by them. So some more conclusions. The providers survey really showed that providers of home care at the moment are under severe pressure. Sustainability of home care providers is a major issue for the social care system, I think, and one of the things that was voiced in the social care green paper, which we're still awaiting, and particularly in terms of assessments, whether providers can take control of assessments or work with the local authority on that. That was a major issue. From the quantitative study, the findings really were that home care does actually work. There is evidence that the objective to keep people at home for longer, there is numbered evidence for that from that study, that it does enable people to remain at home longer, particularly if the package contains more than just personal care plus. That appears to be more effective than just basic personal care. So that concludes my presentation. I'd just like to thank a few of my colleagues there. Elements of this study have been submitted to journals for journal papers, and there's some more journal papers to be submitted very soon. So if anybody wants to know the progress of those, just contact me on the email at the bottom there, and I'll gladly keep you updated. Thanks for your time, everybody.
Thanks very much, Paul. We've got questions flooding in. So I'm going to collapse two questions, one from Catherine Needham and one from Kate Gridley in York.
Yeah.
So in your research, well, certainly in Catherine's research, she's remarked on differences they found across different localities. And I'm going to kind of roll that in with a question around whether you found differences in localities, but also perhaps differences between people who are funding their own care and people who are local authority funded. Did you get any sense of that?
I'll take the second one first, because it is an urgent question, I think, for the social care system as it stands. And yes, particularly from the informal carers survey, informal carers were sort of saying they've given up really with local authority funded care. They're not getting the care that they desire for their relative, and so they're funding it themselves at great cost. So there were differences in carers' perceptions. We haven't analysed the data set, the numbered quantitative data set, in terms of different funding sources, but we do have data on that, so that could be done as a supplementary analysis, and that'd be interesting to work out to kind of dovetail with the informal carers survey. But also from the provider's point of view, I think that that was one way in which informal carers were saying things could be improved if home care providers have a contract with the local authority, not a contract, as it were, with the family carer who are funding it themselves, funding the care themselves. They're much more constrained, home care providers, because they have to follow the contract of the local authority, and they often can't have responsibility for assessments themselves. They have to follow the contract that's set by the local authority in terms of the tasks. So they would prefer to take more control. So there is a difference there, both from the provider's point of view and from the informal carer's point of view in terms of the source of funding. But it would be very interesting, I think, to look at our numbered data as well, to see whether that's, if we cut the data up, for example, into those two groups, whether there were differences.
Yeah. And a comment here from Wendy, who's kind of sort of, I think, endorsing what your observations from the wider sample are, that the people are not happy with the care they're receiving. there's also a question here, well, another couple of points here. So Bridget's asking about whether you had any data on experiences and perceptions of integrated care provision. And also Fiona wants to know whether you had any people with dementia who didn't have family carers in this study.
So again, I'll take the last one first, just because it's easier, Yvonne, in terms of my memory as well, I think. Yeah, we, unfortunately, in terms of that question, the large data set that I mentioned, just because it was one of the inclusion criteria for the wider study on home support, people had to have a carer. Yeah. But it is a very, very important research question, I think, and I understand NIHR a while back, maybe about 8 or 9 months back, did ask that question in terms of a research proposal. Can we work out whether people without a carer that are living alone with dementia with quite minimal support, how do they fare, how do they benefit? And there is an ongoing programme of work that I'm involved with Plymouth University, which I see some of my colleagues from Plymouth, I see their names in the delegate list here, so that's nice, who we're undertaking an NIHR funded programme on dementia at the moment in terms of support from a community support worker specifically for dementia. And in that study, we are trying to explore what the benefits may be to people that don't have a family carer. Your other question was about integration. So we don't have any data from this study on the benefits of integration, but I think that's the way forward for dementia care, certainly. How can we find ways to bring health and social care together, particularly because that is a big issue in dementia more broadly, particularly when we have mechanisms like continuing healthcare, which are really just there to sort out the division between health and social care, who pays basically. And informal carers in particular are completely up in arms about continuing healthcare, about why that should apply to dementia as a long-term condition in the way that it doesn't in other long-term conditions. So yes, integrated care is the way forward to look at dementia support, I think, pulling care together.
Yeah, this will have to be the final point, and if you just very quickly, Francis is asking about whether you were able to control for sort of the level of people's dementia, how severe the dementia was in your analysis.
Yeah, so in the multivariate analysis I mentioned, so I just gave you broad findings on living at home there, but that was backed up with the multivariate findings, and we did control for your level of cognition as well as other factors, particularly your chances of getting a particular service, and we did that in all sorts of fancy ways, which I won't go into here.
That's great, thank you very much. So we're out of time now, but if I could just extend my thanks to, on behalf of everyone, to both Kitty and Paul for really fascinating presentations. I'd like to thank all of you for being here and for your questions, and also to the team at SSCR who put a lot of time in behind the scenes putting these things together so that they run smoothly. Our next webinar is on the 7th of July. It has a focus on intellectual and developmental disability, and I hope that we'll be able to see at least some of you there. And if you could spread the word on that as well, that would be great. So thank you very much to everyone, and I'll look forward to seeing you all again. Thank you.